Obscure gastrointestinal bleeding. Introduction. Obscure gastrointestinal bleeding, OGIB, is a challenging clinical condition encountered in gastroenterology. It accounts for 5 to 10% of all gastrointestinal GI bleeds and is a frequent cause of referral for advanced diagnostic procedures. OGIB poses significant diagnostic and therapeutic challenges due to the difficulty in localizing the bleeding source, which often remains elusive despite initial evaluations. Advances in endoscopic, radiologic, and surgical techniques have improved the ability to manage this condition effectively. Definition: OGIB is defined as gastrointestinal bleeding of unknown origin that persists or recurs after initial evaluation with esophagogastroduodenoscopy, EGD, and colonoscopy. It can present as 1. Overt OGIB, visible bleeding such as melena or hematochezia. 2. Occult OGIB, detected by laboratory tests such as positive fecal occult blood test, FOBT, or unexplained iron deficiency anemia. The causes of OGIB vary based on the age and comorbidities of the patient. Common etiologies include 1. Small bowel causes, angioectasias, most common in elderly, small bowel tumors, e.g. adenocarcinoma, gastrointestinal stromal tumors, Crohn's disease, Meckel's diverticulum, intestinal varices. 2. Vascular abnormalities, Dieulafoy's lesion, aortoenteric fistula, post-surgical. 3. Infectious and inflammatory causes, NSAID-induced enteropathy, radiation enteritis. 4. Other causes, coagulopathies, celiac disease, post-surgical anastomotic ulcers. Clinical evaluation. 1. History, nature of bleeding, overt versus occult, history of NSAID use, anticoagulation therapy, or prior GI bleeding. Family history of gastrointestinal malignancies, symptoms such as abdominal pain, weight loss, or fatigue. 2. Physical examination. Assess for signs of anemia, e.g. pallor, tachycardia. Look for stigmata of chronic liver disease, abdominal tenderness or masses. 3. Risk stratification. Hemodynamic stability. Risk factors for malignancy or vascular lesions. Investigations. 1. Laboratory tests. Complete blood count, CBC, to assess for anemia. Iron studies to confirm iron deficiency anemia, coagulation profile. 2. Initial endoscopic evaluation, esophagogastroduodenoscopy, EGD, and colonoscopy to rule out upper and lower GI sources. 3. Advanced diagnostics, capsule endoscopy, first line for small bowel evaluation, identifies lesions like angioectasias or small bowel tumors. Deep enteroscopy, double balloon or single balloon enteroscopy for direct visualization and therapeutic interventions. CT or MR enterography, useful for structural abnormalities, tumors, or Crohn's disease. Angiography, for active bleeding with hemodynamic instability. Radionuclide scanning, technetium 99 MAME labeled red blood cell scan for intermittent bleeding. Push enteroscopy for proximal small bowel evaluation. 4. Specialized tests, Meckel's scan for younger patients. Endoscopic ultrasound for submucosal lesions. Management. 1. General measures. Stabilize hemodynamic status with IV fluids and blood transfusions. Discontinue anticoagulants or antiplatelet agents, if possible. 2. Endoscopic management. Endoscopic hemostasis for angioectasias or ulcers, e.g. thermal coagulation, clipping. Injection therapy for bleeding varices or lesions. 3. Interventional radiology. Embolization for active bleeding not amenable to endoscopic treatment. 4. Surgical intervention. Resection of bleeding lesions, e.g. tumors, Meckel's diverticulum, when other modalities fail. 5. Pharmacological therapy, somatostatin analogs, e.g. octreotide, for vascular lesions. Iron supplementation and erythropoiesis-stimulating agents for chronic anemia. 6. Follow-up. Repeat capsule endoscopy or deep enteroscopy for recurrent bleeding. Long-term monitoring in cases with no definitive source. Conclusion. OGIB is a complex clinical entity requiring a systematic and multidisciplinary approach for accurate diagnosis and effective management. Advances in diagnostic tools like capsule endoscopy and deep enteroscopy have revolutionized the detection of small bowel lesions, the most common sources of OGIB. Timely intervention tailored to the underlying etiology significantly improves patient outcomes. Further research and technological innovations are expected to enhance the diagnostic yield and therapeutic options in OGIB management.